So I did the very first endoscopic lumbar fusion using the Apple Vision Pro in the world. And so that was from beginning to the end of the surgery. Not like I put it on real quick and then took it off, but from the beginning of the surgery, and I recorded it from the beginning to the end, where we were using the Apple Vision Pro, and you can see from my perspective virtually what I see, basically. And it was a huge advancement in terms of, I think, visualization, because I can now visualize, instead of this 20-inch monitor that's in the OR that's hanging from physically in the OR, I have this virtual screen that's 100 inches. That's 4K right in front of me, and so I can see the anatomy so clearly, and it's huge. The nerve roots are huge. The spinal anatomy is just right in front of my eyes.
Hi, I'm Lindsay Carrillo, Director of Business Development at UCI Health.
Hi, I'm Sunil Verma, Associate Chief Medical Officer for Ambulatory. I'm also a laryngologist here at UCI.
Welcome to Physician Huddle by UCI Health.
So today we're joined by Dr. Don Park, professor here at UCI Health in orthopedic surgery, as well as the director of minimally invasive spine surgery. Welcome, Dr. Park.
Thank you. Thank you very much for having me.
So, Dr. Park, take us through your journey, then what brought you here to UCI Health?
Actually, the new Irvine Medical Campus was the big impetus for me to come to UCI Health. The UCI leadership, including my chair, Nin Bhatia, had recruited me to come to UCI, and they were, during that recruitment trip, showed me kind of the campus before it was really built. And so, they showed me their vision of what they wanted in that campus, and I thought it aligned well with what I envisioned in terms of the endoscopic program that I wanted to develop at UCI. And so that's the big reason why I came. Is that I thought that the Irvine campus and the endoscopic program could marry well together in terms of the state of the art, high tech, delivering the best and the greatest and best care possible in terms of spine surgery, and that's where I thought there would be a great marriage and in terms of those two ideas coming together, and I then decided to come down to UCI.
So tell us a little bit about endoscopic spine surgery and what that means.
Sure. Endoscopic spine surgery is when you take a high-powered camera, usually now 4K camera, and it's a similar concept as arthroscopy. So we've been doing arthroscopy in orthopedics for a long time, putting it in joints, putting it in the shoulder, the knee, the hip, the thumb. We can put it into all sorts of different places now, and now we can put it into the spine. And so we make millimeter incisions, so 4 or 5 millimeter incision for the camera, and about 8 millimeter incision for the surgical instruments. And that's what's called biportal endoscopic surgery. And so uniportal is when you make one incision, you have one camera that then also has a port for the instruments all in one. And so there's two different forms, and I practice both here at UCI. For different reasons. So the uniportal technique is really great for discectomies, for lumbar disc herniations that are easily identifiable and attainable, reachable, so that you can remove them to take the pressure off the nerves that are causing radiculopathy. And then biportal is actually great for more complex pathology. Such as lumbar stenosis, even severe critical lumbar stenosis that develops over time with older folks. It's a very common problem that a lot of patients have, and you can address that just like you would with the same kind of results as open surgery, except now with tiny incisions. And these patients are able to wake up right away with no pain. They're able to walk right away. They're able to recover fast. And so there's a lot of benefits, and it's really shown throughout the literature to be quite effective in that way in terms of reducing pain significantly, making the recovery fast, making it so that we can do an outpatient surgery. Before I came here, most of the spine surgeries were done inpatient. And so I developed the endoscopic and outpatient spine program here at Irvine. And I wanted to shift a lot of the surgeries that we were doing in this hospital and as an inpatient and take it to the surgery center. And that's when the Chow Center, the ASC that opened in the Irvine Medical Campus, when that was finally opened, we were able to then really shift a lot of those pathologies, those cases to the outpatient setting.
Can I ask why the lag? So minimally invasive surgery is not new, been around for a long time.
Right.
So why is spine taking so long to reach this threshold?
Well, minimally invasive spine surgery has been around for a long time. I learned it when I was a resident as a fellow, 14, 15 years ago. And so that's something that's been around, but it's slow to adopt because it's just not that well trained in fellowship residency programs.
Mm-hmm.
And then if the residents and fellows aren't seeing it, then they're not going to be looking for it. They're not going to be trying it because then they're going to have to learn it in practice. And that's hard. And that's where there's a big learning curve for anything that you learn outside of your training program, right? And so that's where in minimally invasive spine surgery, it hasn't really been adopted well.
Mm-hmm.
And endoscopic spine surgery, which is even newer, a subset of minimally invasive spine surgery, the adoption has been quite slow. And that's because of the learning curve. When you take that learning curve during practice, it's difficult. It's a steep learning curve. You have to, do new things with patients that you haven't done before. So that's scary. That's daunting. So you're not going to be just trying that out unless you do, your own training. You go do labs, you do hands-on training, you watch surgeons, and that's what I did for 3 years, learning this. I first learned about it in 2017 in terms of endoscopic spine surgery, and then it took me 3 years to finally do it. And I took a trip to go to Korea during COVID because they had nothing else to do. And so I went there, learned. They were doing endoscopic surgery for 10 years before that. And so then they got all the answers. They were able to really develop and hone safe practices, get protocols down, and say, if you do this, you will be safe, it'll be reproducible, you'll be able to accomplish the surgery. And now it's not just discectomies, it's stenosis, it's spondylolisthesis, it's fusions, it's cervical, thoracic. And so when I saw that, I was like, wow, it's not just this little tiny subset of pathology in patients that I can help with this, which I thought that was my initial impression when I first learned about it. It's actually, I can treat most common pathologies that you see every day in clinic and that you take care of in surgery with this endoscopic technique. And so that's where, for me, I said, oh, wow, okay, now I know I have the answers. Then I came home, came to the U.S., and started doing it. And so, and then it's been accelerating since then.
So we have a lot of spine surgeons here. You're an addition. So as a system, do you figure out a way to offer this technology to patients, recognizing that you're one of the few people that do endoscopic spine surgery here? I mean, I don't think your mission here was to come and make everybody an endoscopic spine surgeon. Mm-hmm. So there still are traditional spine surgeons here. So how does a patient navigate through this system to end up with the right doctor using the right technology?
Right. A lot of patients are very savvy, especially in Orange County. And so they are looking for it. And I see the fourth and fifth opinion on surgery, and they've been given like, oh, you can do it this way, that way, and so it is difficult sometimes to really kind of get the right answer sometimes with patients from the patient perspective. And so a lot of times patients will come to me not just from the outside, but of UCI, but inside too with my colleagues, because they know what I do, and so they're like, well, maybe this is better for you, and so we're quite collaborative that way. And we're able to really say, maybe endoscopic surgery would be a right answer. And the patients are looking for it too. They're like, well, do you do that? And they're like, no, but we have someone who can do it for you. So then they'll refer it to me, and vice versa. I'm like, I don't think you're a candidate. I wish I could do this surgery for you because, I'd love to be able to apply endoscopic surgery to everything, but I can't. There are certain things like deformities that just need to be taken care of with open surgery, traditional techniques. And so then I refer those patients to my colleagues who then do them on a day-to-day basis. Because what I do when I was recruited here, it's like, okay, I only want to do endoscopic spine surgery and outpatient spine surgery. So I really want to make that my practice as my focus in terms of clinical care, but also research and education. And so, I'm just focused on endoscopic and outpatient spine surgery. So things that are beyond that, I used to do. But now it's I am able to then have my colleagues take care of those patients, and so that they get the appropriate care. because it's not. And a lot of patients come and they say, "Oh, well, I want that, endoscopic technique." You can't do that with every single case. There's a lot of pathology you can take care of, but there's certain things that require just traditional surgery.
And what's been the response? I mean, you just touched upon, apart from delivering clinical care, the missions of education and research. What's been the response of learners here to having a full-time endoscopic spine surgeon? What have the residents and fellows said to you, or what do they think of the cases you're doing? Because the way you sort of were illustrating it, maybe it was a black box for them before.
Mm-hmm. Yes, it was definitely a black box, and their minds are blown. Their eyes are open, and they're just like, "Wow, you can do it this way." And because I have the monitors, the OR monitors, they're showing the endoscopic video. It's in 4K, and so they can see what I see, and that's actually the whole staff in the OR can see what I see. And so sometimes I'll see anesthesiologists. They'll look over and they'll watch surgery as it's happening, and the OR staff, and they're involved with the surgery. They're like, oh, they know the next instrument that I want based on what they're seeing, and so the residents and fellows too, they're really engaged with this. We went from, a small fellowship of one fellow to now 3 fellows. We've now matched successfully, our top choices because of this, because now, the applicants are excited about endoscopic spine surgery. So they are seeking this out. And there's maybe a handful of fellowships throughout the country who are offering endoscopic surgery, deformity surgery,
right,
trauma, tumor.
The whole 9, yeah.
It's like very well-rounded.
Plus here is a multidisciplinary fellowship too, right? So they're not just working with orthopedic surgeons, they're also working with neurosurgeons and then all the other members of the team as well. So I think that I would imagine adds out a lot rather to the training experience.
Oh, definitely. Yeah, I think that's one of the huge strengths of UCI Spine Center is that we have neurosurgery and orthopedic surgery working seamlessly. Like we really don't, interact any differently than if we were in the same department. We look at each other the same. We have rotations for the fellows. And so the rotation for me right now is me and Dr. Michael O, who is a neurosurgeon.
Right.
And so, it's like then they get that combined, experience. They can see, okay, this is how you do endoscopically, this is how you do it open, or even other minimally invasive techniques. And so it really is a well-rounded experience and education for the fellows and the trainees.
Well, and I think obviously you have this drive and you want to learn new things and challenge yourself, but you're breaking ground in other ways. And I imagine you're starting to get a reputation. So to that end, tell us a little bit about the Apple Vision Pro, because I know you did something really unique there. And I'm guessing a lot of people are starting to pay attention to that, like future residents and fellows who are like, I want to go there.
Right. Yeah, so I did the very first endoscopic lumbar fusion using the Apple Vision Pro in the world. And so that was from beginning to the end of the surgery. Not like I put it on real quick and then took it off, but from the beginning of the surgery, and I recorded it from the beginning to the end, where we were using the Apple Vision Pro, and you can see from my perspective virtually what I see, basically. And it was a huge advancement in terms of, I think, visualization, because I can now visualize, instead of this 20-inch monitor that's in the OR that's hanging from, physically in the OR, I have this virtual screen that's 100 inches. That's 4K right in front of me. And so I can see the anatomy so clearly, and it's huge. The nerve roots are huge. The spinal anatomy, it's just right in front of my eyes. I can, at the time, I could also put the PACS, and the imaging virtually right there, and the EMR right there. So if I wanted to look at, all other information, I have it virtually set within my headset, so I can see it I have everything in my fingertips, basically. And so I published the case report on that, and then now we have a series that we're going to be publishing on how we've been using the Apple Vision Pro, how it reduces workload for the surgeon. So it's ergonomically better because I can set the monitor basically wherever I want virtually. And after a while, you just don't really pay attention to the weight of it. It's not that heavy. after you get used to it. And so for me, there's a lot of advantages, and so trainees are just like blown away. They're like, wow, you're doing that. You can do that too. And pretty soon I have research funding for this. And so I'm getting another Apple Vision Pro for them.
Nice.
So they can see, what I see. We can do it together. We can have virtual, reality surgery together, kind of thing, simultaneously. So I think that's something that's going to be quite interesting. And so a lot of trainees are just like blown away by this. They're like, "Wow, you're doing things that not a lot of people do around the country or even in the world." So that really draws a lot of talent. I think a lot of interest. To UCI.
So how do you answer the patient that says, geez, spine surgery is already, in such demand and there's so much technology. So folks like you must be getting knocked on the door by industry all the time. Try this tool out, try this tool out. But then if I'm a patient, I'm also thinking, I don't need you to experiment on me, right? Like I need you do something you've done 4 times before. And also, how do you set up that barrier, that shield that says, I don't need to try every single tool out? How do you vet all this? Right. Because you could spend your whole life doing one-offs and writing individual case reports. That can't be all that satisfying. So what do you use to judge what's a good tool and what isn't?
I think a tool has to make me better. It has to make the surgery better, more efficient, safer. I think those are the things, the criteria that I use to say, am I going to use this tool or not? And so I'm vetting that all the time. So yes, I get, companies that say, oh, use this. And it's like, well, how does this make me better? How does it make me do the surgery better, more effectively and safer for the patient? And so, say the Apple Vision Pro, that's something that Apple didn't, come to me and say, hey, use this for surgery. It was more that I was like, I wonder if this could make me better because I can see so much better. I can have, I'm just like, in the OR, I'd always be, before I use the Apple Vision Pro, I'd have to step away from the patient, go to the monitor that had the packs,
have somebody scroll through it for you.
Yeah, because I'm scrubbed in.
Right, I know. Well, we've been there. Yeah.
And so, it's like, oh, that's so annoying. Well, how about have it virtually there? And then I could, ask Siri to, bring this up or, move this up or down, or I could do it with my gestures and things like that. And I was like, oh, well, why don't we try that? And I was, when I first started doing it, I always consented the patient. I still do consent the patient for it, but I would tell them, well, if there's any failure of the technology, well, I just take it off and I just use what I have still there. It's all working in the OR anyway, in terms of the OR monitor, the PACS machine, it's all there. It's just now I'm doing it with this headset on my head.
Got it, yeah.
And then patients are like, oh, okay. Like there's no downside really. There's no risk to the patient other than, if it doesn't work, I just take it off and I just use what the normal techniques and the technology would be. But then there's other things like, bone graft material and implants and things like that, or, disc replacements. There's all these different various companies that have similar things. So how do I, kind of tease them all apart? It's just more, like, is there something about that product that makes this surgery better, that pushes it forward?
And if it does, then that's
not the same thing over and over again, or, because they all look the same. Are they all doing the same thing? And if it is, then it's like, okay, I don't need that. I need something that will help me.
Because I really think that the best surgeons are the ones that understand how to say no more than saying yes. I think if a surgeon is always saying yes to the newest technology and just always trying it, then I think what we really have to rely on is that we will not always be first to market. You have to trust that other surgeons in the area or in our field will be able to vet it. And then also vet it with just, I think, healthy skepticism as well.
Right.
And I think oftentimes there's a suspicion of academic surgeons because we are too potentially biased towards new technology. And so I'm sure you face that at meetings and you face that in conversation as well.
Right. For endoscopic surgery especially.
Right.
No, so it took me 3 years to actually do it though. And during those 3 years, and in the very beginning, I was very skeptical. It's like, show me the data. What's the research? Is this safe to do? What are the complication rates? Those are things that I'm always asking, with any new technique or anything, and I don't adopt it quickly. I just happened to be the first adopter of this in the U.S. when it wasn't really adopted at all.
Yes.
But
Yeah.
because I heard about it so early, and so, but I just kept on asking. I would stand at the podium or, stand at the microphone when they're giving presentations at conferences. Well, what about dural tears? What about hematoma? Like, what do you do with that? How do you prevent that? And so they would, try to answer and, the best they could. And then the papers would start coming out. And so you read the papers. And so you're accumulating this knowledge. And at a certain point, I said, okay, this is safe.
Yeah.
So then is it, reproducible? Is it something that I can then apply easily? Is it something that will make me better? If it's harder, it takes longer. If it's, equivocal results, then why? Why do that? So that's where I'm always asking those questions.
Talk to us about the future of spine surgery, because, it seems like you're really scanning and looking for what's coming next. Like, what are you excited about, or what are you starting to hear about that maybe you think will be adopted in the next few years?
Well, definitely there's a lot of talk about AI. AI in spine surgery. There's talk about using AI to help, with, indications for surgery, selecting patients, who are the proper patients to have surgery, as they go through thousands or millions of patients, and get that data. But also intraoperatively too. So, can we develop AI protocols or programs that help us to understand, well, what is the next best step of surgery that is the safest and most effective way of doing the surgery? And so, I think that's where AI could help us. Right now, we're developing ways to endoscopically see through bleeding. And so, when things bleed in surgery endoscopically, everything turns red.
Yeah, floods your field.
See anything.
Yeah.
And so then it's like, okay, where is that bleeding source? And can AI help us identify that based on where things started? And say if we haven't really shifted our viewpoint, all we did was all of a sudden things got red, can it identify where that is relative to, say, something important like a nerve root, like a nervous structure, and be safe about it? Because if you can't see, then how are you going to cauterize it, without injuring the nerve? And those are the kind of things that I think we really use visualization for, in terms of our human eyes to visualize where the source of bleeding is, so we can cauterize and stop it. But can AI help us with that?
So it sounds like it's not a replacement, but more an adjunct,
Yeah.
right, to what you're doing.
I believe that's how I think AI is going to be, in my perspective. And I have a very optimistic outlook on AI and robotics in surgery and spine surgery. I don't see it replacing us. It helps us in ways to make us better, to make us more efficient, make us safer. I think that's where AI really should come in, not to replace the surgeon. To help us to understand who are the right patients to have surgery. What's their probability of success? What's the probability of failure? Should we be doing this at all? Those kind of things are I think we use experience, our clinical experience, our number of years in practice, and our successes or failures to guide us in that decision making, right? Our clinical decision making in the clinic, preoperatively, intraoperatively. But then can AI, with say millions of moves,
Right,
tell us these things? And we don't have to follow what AI tells us, but say, like it says, well, if you do this next, if you take this instrument and put it here and do this, then you're actually going to be able to accomplish what you want to accomplish. And if a lot of us are very thick, thick skulls, and so we're going to not want to do that, and then realize, oh, well, if I had done that, then that would have been the better way to go, maybe,
Yeah.
So those are the kind of things I think will kind of help augment us as surgeons.
So how do you balance, one of the missions also with the spine surgery program is education of colleagues around the country, and you throw a lot of conferences. So what suggestions do you make to a spine surgeon that's been in practice for 5 to 20 years, doesn't really matter, didn't have a mentor like you in residency or fellowship? but then wants to start introducing this, but wants to do it safely and doesn't have COVID in Korea as a resource?
All right. Well, definitely go to as many courses as possible. Go to as many conferences that is holding some sort of lab, whether it's synthetic material models to do the labs, and then or cadaver labs, and then also go to the centers where they do a lot of them. And I have surgeons come from all over the country to come and watch me do the surgery, so they're with me all day. And we even have a way where you can do a cadaver lab before,
Oh, wow.
and then go to the surgery the next day, and so they can watch it in practice in a live patient. And so I think seeing how I set things up, how I hold things, how I do things with my staff to have the most efficient way of doing these surgeries, I think is helpful. And so I think those kinds of experiences, and then I'm always available as to answer questions, to help them through any issues that they may have, whether it's getting things started at their hospital or ASC. I'm always open to questions, and I always answer them right away. It's like, yeah, you should do this, and this will help you a lot. So that way, they have a resource, so that they are successful. Because their success will then help me be successful too, because then it's going to be, expanding. We want endoscopic surgery to expand in the U.S., to be proliferating like it is in other parts of the world. In Asia, it's huge. It is. There's patients will refuse to go to anyone not doing endoscopic surgery nowadays. And so everyone then has to learn how to do this. So their adoption is sky high. Wow. It's through the roof.
As a swallowing specialist, it's gratifying for me to hear about this, because a good amount of the patients I see are status post ACDF and have dysphagia or have a Zenker's diverticulum, a traction diverticulum afterwards, just because of the proximity of the esophagus and pharynx to the operative spine or operated spine. And so to me, I just see the value and benefit in minimizing dysphagia, voice problems for patients if we can offer them a technology that is minimally invasive and thus has less morbidity.
Right. I think that in the anterior cervical spine, it's difficult to do without an anterior approach, ACDF, cervical disc replacement, but the profiles of the plates and the screws are getting thinner and thinner.
And who knows, if we have this conversation 5-10 years, you may say, hey, we've figured it out. Right. We've been able to do it differently. But I think that's sort of, for me, one of the holy grails of spine surgery and dysphagia.
Right. And definitely reducing the trauma to the anterior cervical spine. So if you can do it posteriorly, I mean, this is kind of goes along the lines of what we were talking about before, but there are surgeons in Korea who are doing endoscopic ACDF. So I was like, okay, that's interesting. I'm going to watch that for a while.
I like that.
I'm not going to just, when can I do that next? It's more like, okay, how are you doing that? What's the advantage of this? And is there some sort of problem that can occur doing it, and it's kind of with all that water flowing out through the neck? Like, is that okay? Like, those are things I'm asking. I'm always asking: is it safe? Is this the right thing to do?
Nice.
Well, great conversation.
Yeah. Well, thank you.
Yeah, thank you both so much for being with us.
This has been Physician Huddle by UCI Health. Thank you for joining us.
This was an episode of the Physician Huddle podcast by UCI Health, produced by Brett Shahian, Angelica Yagubi, and Victor Ting. For more episodes, information on clinical trials at UCI Health, or to refer a patient, view the show notes or visit clinicalconnection.ucihealth.org.